started. See some more people are just joining now. But thank you so much everyone for joining today's webinar. My name is Jacqueline and I'm one of the co-directors of the Public Health Youth Association of Canada.
And my name is Maham and I am one of the co-directors of the Public Health Youth Association of Canada. For those of you who are unfamiliar, the Public Health Youth Association of Canada is a recently formed national by youth for youth organization aiming to increase youth leadership in the field of public health in Canada.
So fortunate to be joined by Dr. Sohail Gandhi as our for this webinar. So Dr. Gandhi is the immediate past president of the Ontario Medical Association. He has practiced rural family practice in Stayner, Ontario since 1992 and holds hospital privileges at the Collingwood General and Marine Hospital. Dr. Gandhi is a graduate of the University of Toronto and has worked as an assistant clinical professor at Queen's University Medical School and a lecturer in medicine at the University of Toronto. He has also held leadership positions at both the Ontario Medical Association and in the community, including the medical staff executive and chief of family practice at Collingwood General and Marine Hospital and chair of the board of the Georgian Bay Family Health Team. And Dr. Gandhi has been awarded the Queen Elizabeth II Diamond Jubilee Medal for dedicated service to peers in the community and the Award of Excellence for the Ontario College of Family Physicians. So thank you so much, Dr. Gandhi, for joining us today.
Oh, thank you. Thanks very much. It is a pleasure to be here. I always enjoy talking to people who are keen and eager and want to learn about things, and so it's actually an absolute pleasure to be here and just share with you some of the thoughts I had about public health in general, and also how public health has responded to the COVID-19 pandemic that we're currently involved in. I'm not going to rehash a lot of what was said about me before in terms of what I've done, but there are two things that I think is very, very important for people who are on the line to know about. The first thing is that I started my career as a family physician. I'm still a rural family physician, and I'll probably end my career as a rural family physician. It really sort of defines who I am and what I do. I go to the hospital first thing every morning, see my patients there, and then go to my office and see all my outpatients. And the second thing that I think is important to know about is that I happen to be the president of the Ontario Medical Association when the COVID pandemic hit, and I continue to sit on the OMA's COVID-19 action team, which means I do have a little bit of insight into how the government has responded, how public health has responded to the pandemic, and I'm happy to share some of my thoughts about that with you. And what you'll see out of all of that is the one thing that I definitely am not is a public health specialist. Okay? So I'm not someone who's very versed in public health, who knows all the ins and outs of it. That's okay, because as an on-the-ground frontline family physician, what I personally would like to share with you is my personal insight on how public health handled the COVID-19 pandemic in Canada, and what we need to do to make things better, because I do believe we need to make some changes. So when I prepared for this topic, I must admit the first question I asked myself is, what exactly is public health? And I know there might be a couple of people who are on the line who are not familiar with what the definition of public health is. And the best definition I could come up with was something that the CDC said from the Center for Disease Control from Atlanta. And they defined public health as the science of protecting and improving the health of communities. But they further went on to define what a community was. And a community could be really what you make of it. It could be a neighborhood, it could be a city, a province, a country, or even the whole world if you're talking about an organization like the World Health Organization. And while it's true that public health plays a large role in trying to control disease, and that's one of their main aspects of it, I think it was also important for me to recognize that the role of public health is also to promote wellness by encouraging a healthy lifestyle. And these are the usual stuff, right? Don't smoke, eat healthy, exercise, don't do drugs, all the usual there. But also, and this will become relevant to our response to COVID, by promoting healthy standards. And standards such as sanitation, fluoride in water, food standards, all of this stuff that public health really needs to promote to ensure that we have a healthier lifestyle. And importantly, what this means is that public health is not a single science. And that becomes very relevant to how we handled COVID. And I'll go into that in a minute. Because what we need is we need a whole bunch of different sciences that are coordinated, that are integrated, and work together. So you can't just have, a virologist in public health. You need a virologist. At times you'll need an immunologist. At times you'll need an engineer. If you're talking about sanitation standards and air filtration standards, sometimes you'll need, geologists, depending on what's involved. So there's a whole bunch of different types of science that go into a high-end public health response. And what's important is they need to be coordinated, they need to be integrated, and they need to work together to give a positive and the appropriate message to the rest of the population. Now, public health, of course, is usually in the background. And I say this because people generally don't talk about it very much, unless, of course, there's a major incident. And quite obviously, this past year has been probably the most major incident, certainly in my lifetime, and probably since 1918. And that's why public health is now more than ever in the minds of the general public. The question that I had to ask myself and was also, how effective was public health in Canada to begin with? And before I answer this question, I'm reminded of a comment that the CEO of the Ontario Medical Association makes on a regular basis. And what he says is, it's always, you need to be hard on the problem, but don't be hard on the people. And I say that because I am going to be making some pretty critical comments of how public health is structured in Ontario and in Canada. But I want to emphasize that when I was president of the OMA, my president's tour was in the fall. And it happened that it was around the time of flu shots, right? It was flu shot season. And so one of the things I did is I got a chance to tour a lot of the public health units in the province. And it was actually a focus of my president's tour. And I came to appreciate that the public health physicians and staff were all good, hardworking people. And they really were very, very dedicated to trying to improve the health of their communities. But I have to tell you, the reality is, what I also discovered was that our public health system was quite fragmented, wasn't really integrated. And this was all prior to COVID-19, because my president's tour was in the fall of 2019. And so I found that the system itself really wasn't working very well. But because public health is usually in the background, right, unless there's a major incident, the ramifications of the fact that public health in Canada wasn't integrated and wasn't following a clear communications path, those ramifications were quite frankly, they were ignored. And as a result, the ramifications of us not having an integrated system are really, really being felt now in our response to COVID-19. And it reminds me of a quote by Lawrence J. Peter, who said that bureaucracy defends the status quo long past the time the quo has lost its status. And I think that this is really a very telling statement about how we've got a certain amount of inertia in public health, and we really need to fight that inertia to improve the system in the future. And to understand one small example of how things worked in public health, I wanted to talk about trans fats. And I know some of you who are on the call are probably saying, we came here to talk about COVID and see the response. What's this talking about trans fats for? I hope it will make sense, and I do hope to tie this in the future towards the end of my presentation. And I hope you can bear with me on this. But let's talk a little bit about trans fats and cardiovascular disease. It was back in 1993, so almost 28 years ago, that the World Health Organization realized that trans fats were linked to cardiovascular disease, and that people should reduce the intake of trans fats, right? And it was in 1995, so 26 years ago, that Canadians were found to have one of the highest intakes of trans fats in the entire world. So this is a problem that we've dealt with for a very, very long time, over a quarter of a century. Denmark by example, has a very, very strong public health system. And their public health system is integrated, and by that I mean they all use the same, all the departments of public health use the same software, report to one agency, and was able to collect a lot of data. And because they were so passionate about promoting public health, their country in 2004, so 17 years ago, was able to achieve a ban on trans fats to no more than 2% of the fat in any product. And that was 17 years ago. And that was clearly because of their public health department. And within 2 years, the number of deaths from heart disease fell by 4%. And I want to emphasize something. That's just the number of deaths here. We're talking about people who died from cardiovascular disease. We're not talking about people who had a heart attack but survived, then went on to have other problems afterwards. We're talking about just the number of deaths, which is a dramatic reduction in cardiovascular disease. And when you look at Canadian data, it actually suggests that regulating trans fats would avert over 600 heart attacks a year. And that's just heart attacks. I didn't get a chance to dig up the number of strokes, the number of amputations of legs from poor circulation and other illnesses that could be prevented if we enacted the same legislation. And when you look at the Canadian response to something like this, it was in 2007 that the City of Toronto actually proposed a ban on trans fats in restaurants. And the City of Toronto is actually, I will say, has always had a very forward-thinking public health department. Dr. Eileen de Villa, who I had a chance to meet last year, has done a great job in her communications around COVID-19, and that public health department has always been very forward-thinking. But the problem is that they can make a recommendation, but there are 34 other public health units in Ontario. And while they probably all do agree on the need for limiting trans fats, there was no agreement on how they should promote this. And there was no agreement on how they could bring this up. And of course, the restaurant industry was like, well, how can we buy one set of food in Toronto, but another set of food somewhere else? And it wasn't until 2009, and this was primarily because of the City of Toronto, that Public Health Canada actually suggested voluntary guidelines. And of course, the restaurant industry and the food industry said, well, they're voluntary. That means we don't have to follow them. So of course, we still don't have a ban on trans fats. And it wasn't until April of 2017 that there was a notice of proposal to limit trans fats by Health Canada. And I want to stress to you, this is not the law. It is simply a notice of proposal, right? And here we are 4 years later, and nothing's happened with that because we have such a disparate amount of public health units. They don't oftentimes communicate with each other. They don't sort of coordinate what, and they don't rank what fields or what areas they should promote. And that disjointed approach to things has really, I think, hurt the Canadian public. And when you look at the costs, and I'm just talking about the economic costs, right? I'm not going to talk about the emotional costs, of which there are many, of having a heart attack, and the cost to the family and all that. Cost of a heart attack is $70,000 in what we call the acute phase. So if you're admitted to hospital with a heart attack, you spend a day or two in the intensive care or the coronary care unit, you maybe have an angiogram, that 4 or 5 day stay is about $70,000. 600 heart attacks a year, that's $42 million a year just in the acute phase that we could have saved if we had an integrated public health system. And I use this as an example to point out that there were always issues with public health, but without a unified, coordinated voice, it's really hard to affect changes. And this is important. This is the cover from a report that the World Health Organization did when it talked about investing in public health. And it talked about the summary report. This was presented to the European Union's Public Health Organization. And the World Health Organization did a very smart thing with this report. They talked about how disease prevention was cost effective in a business sense, right? Because they were talking about investing to save money in the future. They knew that they were targeting a business audience who might be resistant to some of the new rules that they wanted to put in place. And they talk about vaccines, and they talk about social determinants of health, education, and trans fats. But the key thing that they did in this report was they used business terminology. They said early returns of investment. And they talked about those early returns on investment being 1 to 2 years, right? And that in terms of saving money. So why do I tell this story when I should be talking about COVID? I tell this story to point out that this kind of lack of integration existed in Canada for a quarter century prior to us getting into a pandemic. And when you think about it, if we can't, we have 10 provinces, all of them do things differently. In a province like Ontario, we have 35 public health units. Some of them some of them aren't electronic. So some of them for their medical charts still use paper. The tracking systems are different from one public health to another. There are like 5 or 6 different pieces of software that the public health units use, and they all don't use the same one. So we have no ability to focus and coordinate a response to a public health crisis. And just as we saw before a crisis, we couldn't actually achieve something as simple as ban on trans fats. We're in a situation where now we couldn't achieve an effective response. And in fact, you've got people like myself. I'm actually on the border between North Simcoe, Muskoka Public Health and Grey Bruce. And what that means is if I've got a reportable disease in one of my patients, I have to look up which public health unit they go to. They use different reporting mechanisms in different forms, and the forms are laid out differently, so I have to figure out which one to use. And they don't communicate with each other either, which impairs our ability to track any disease, right? So it's a very, very difficult situation. If you look at what this lack of integration means when it comes to messaging, I'll use this particular example here. This is from November 4th, 2020. And Canada at this point, Health Canada, updated the COVID-19 guidelines and said, yep, a major reason that COVID is spread is because of aerosol transmission, because of airborne spread. Now, this was probably a little bit too late, and I'll discuss that in a bit. But here was Health Canada, the leading health agency in our country, saying, yep, COVID is aerosolized spread. It's bad in closed environments. This is why it spreads in restaurants, gyms, and things like choir practice, because it's all aerosolized. If you read their memo, it talked about the need to protect against aerosols with masks, and it talked about proper ventilation, and it talked about using air purifiers, and it talked about how we needed to make sure the air was circulated a certain number of times regularly. But this here is a snapshot from the Simcoe Muskoka Public Health Unit from January 10th, 2021. And this is 2.5 months later. So after Health Canada said aerosolized is major. And if you look at it, it says COVID-19 is spread 2 ways: person to person in close contact, or by surface or objects, right? So you've got the Simcoe Muskoka Public Health Unit not mentioning, because there's no coordination, right? So they're not mentioning and not giving a consistent message to what Health Canada did. And you can just imagine how confusing that is for the general public. I will acknowledge that if you read the entire, and it's about a 10-page document that Simcoe Muskoka Public Health put up, there's one bullet in those 10 pages that says, oh yeah, make sure that you ensure good ventilation by checking your HVAC. And that's it. It does not go on to give you guidelines on how to ensure this is the case, whereas it continues to, whereas if you read that document, it gives you guidelines on surface objects, right? It talks about disinfecting with certain kinds of disinfectant, leaving a room open if you're seeing, in my case, if you're seeing patients, or if you're seeing your customers in that room. And it talks about how often you disinfect and how often you wash your hands, that sort of stuff. There's only that one bullet on good ventilation. There's no guidelines in Simcoe Muskoka's public health that I could find on filters, air purifiers, what you should put into a room. And so there's a disconnect there that is very confusing for the general public. For those of you who may be interested, the guidelines should be that you have a HEPA air filter, air purifier, that's capable of exchanging the air in your room a minimum of 4 times an hour, and ideally 6. So most air purifiers have something called, I'm trying to remember, it's a CFR rate or a CFL rate, but it's a flow rate, and it gives the size of the room that the HEPA, the air purifier is certified for. So you need to buy an air purifier that's certified for the size of your room and can exchange the air that number of times with a HEPA filter. By contrast, so The question, of course, becomes if public health is so fragmented, this simple message can't be consistently presented, how are we going to fight a pandemic? By contrast, let's have a look at Japan. So this is a diagram from Environment International. This is from an article the Japanese Public Health Department put into Environmental International. And this indicates what Japan did right from the beginning for COVID. They decided they had a consistent message that everyone in Japan was told. They do have a number of branches. When you look at their public department, yes, they've got a number of different public health branches in local communities, but they all report up using the same software, they all communicate using the same language, and they all have one consistent message once information is collected. And for whatever reason, Japan decided, quite rightly it turns out, that aerosolized spread was something they were going to focus on. They were going to talk about portable infection on a regular basis in each of their anywhere that was available in Japan. And it's interesting to note that Japan operated on this assumption. I found out it was actually February of 2020 when they started using this consistent message, whereas the World Health Organization didn't acknowledge this until July 13th, 2020. And of course, Health Canada didn't acknowledge this until November 4th, 2020. Japan focused on diluting the amount of virus in the air by opening windows. And so, you know, those commuter trains in Japan, I'm not sure if you've seen pictures of those. They all look, people are really crowded inside them. Japan now opens the windows in the commuter trains. So everyone's in there, they're still packed close together, but they're all wearing masks and the windows are open to try and recirculate the air as much as possible. And their single health authority is the one that speaks to all of Japan with one common and consistent voice. And when you look at their response to COVID-19, Japan has a population of 125 million, right? Their size is 378,000 kilometers squared. And to put that in perspective, that's about 75% of the size of Baffin Island. They really are smaller than one of our islands. And I mention that because we know that one of the risk factors for COVID-19 is being in close contact, right? So we've got a country that has a reasonably high population density. People are really close together. And they have had 280,000 cases of COVID-19, which represents 0.224% of their population. And they have had up till now 4,000 deaths, which represents 0.0032% of their population. And that figure is as of January 10th, 2021, which is when I put this slide deck together. That number has gone up since then, but we'll use that as the date. Similarly, our lack of integration hurt the pandemic response in other ways. So again, if you've got public health that's very fragmented, the way that we are right now, again, no fault of the people, by the way, it's just we're talking about the system here, right? How do you test, trace, and isolate when all systems throughout the country are disparate? When BC does something different than Ontario, and Ontario has 36 different units, and so on. To use an example, again, me as a rural doc, if I get a patient who turns out positive for COVID, I then have to check the address of my patient, find out whether they're in Simcoe, Muskoka, or in Grey Bruce, which are my two health units, use the appropriate form, and then report that, which is a little bit confusing. I'd rather use the one form. But here's the thing. Simcoe, Muskoka, and Grey Bruce, they use two different software systems, so they can't easily communicate with each other. And here's another thing. What if I've got a patient who lives in Grey Bruce and works in Simcoe, Muskoka? How do we do proper tracing? Which public health unit is responsible for the proper tracing in that scenario, especially when they can't communicate with each other? And so essentially what we found in Canada is that we couldn't really, we just didn't, right? We didn't test, trace, and isolate the way that they have in other countries. If we look at the example of a country like South Korea, South Korea initially had the highest number of cases of COVID-19 outside of China. Now that's the first month or two that the COVID pandemic started, but that's what they had. But importantly, South Korea has one health agency, and they do have a number of smaller branches throughout their country, of course, but they all report to the one agency. And they have an infectious diseases plan that's updated every 5 years. and includes the learning from previous pandemics. So, we had SARS in 2001, I think, and then after that there was MERS a couple of times. So we had a couple of different pandemics, and South Korea uses the learning from those and updates their plan every 5 years. Again, one health authority, all using the same software, the Korean Ministry of Health and Welfare. And their health authority actually had a number of relationships with the private sector. So what they were able to do as a health authority is they were actually able to design a COVID test kit, a rapid test kit. But because South Korea has a number of manufacturers, they are able to contract out 4 different private manufacturing firms to begin mass production of the rapid test kits. And as a result of that, plus their open communication. So here in Canada, if you read the newspapers, David Williams, who's the Ontario's public health officer, sometimes is in a news conference. You'll hear Eileen de Villa if you're from Toronto. You'll hear Chris Mackey if you're from London. Sometimes you'll hear Theresa Tam. Korea didn't do any of that. They said, we need to get out in front of this. We have one press conference from the top, so it's for the whole country. They felt that because there was concern around test, trace, and isolate, they felt that there would be some concern about privacy issues, right? Because people are talking about, well, you're tracing me through my cell phone, and how you're tracing me. So they had a philosophy for their communications that they use with every press conference that they started with. And their philosophy was be right, be first, build trust, express empathy, and promote action. And so their press conferences were all built around using this philosophy. And same thing, consistent message to the people of South Korea, not 4 or 5 different people, but from one source. Everything coordinated through one agency and integrated. So let's look at their response to COVID. South Korea's population is 51.7 million, according to Wikipedia. Their size is 100,000 kilometers squared, so 20% the size of Baffin Island, right? Not a very big country geographically, and certainly very, very high population density. 68,664 cases of COVID, which is 0.133% of their population. And they've had 1,125 deaths, which is 0.0022% of their population. This is off January 8th. For some reason, South Korea didn't update their COVID website on January 10th, so I'm off by about 2 days on this one when I compare to Japan. But that was their response to COVID. So in comparison, let's have a look at Canada, where we have, disparate health. Everyone wants to do the right thing, but can't share information properly, can't test, trace, isolate, can't communicate a consistent message without, unfortunately, for a bunch of reasons. We have a population of 38 million. We are almost 10 million kilometers squared, so we're 99 times the size of South Korea, 26 times the size of Japan. For those of you who are into 90s music, there's a group called the Arrogant Worms. It's a Canadian comedy group. They've got a song called Canada's Really Big. Look up on YouTube. It's hilarious, and it talks about just how big we are as a country. And I point this out to show that our population density is quite a bit lower than Japan and South Korea. And yes, I am aware that 80% of the Canadian population lives within 200 kilometers of the US and US-Canadian border. But still, we have a fairly low population density, even when we take that into account. So we've had 659,000 cases of COVID, which is 1.73% of our population. And this is 13 times as many cases on a prorated basis as South Korea, and 7.7 times as many as Japan. If you look at our deaths, we're at 16,933, which is 0.0445% of our population. And that's 20 times as many deaths on a prorated basis as South Korea, and 14 times as many as Japan. And those figures are as of January 10th. So, it's 9 days later. Those numbers have also gone up, but I was trying to be consistent with when I compared the data. So it's difficult to look at this response that we've had to COVID-19. It's very difficult to say that in Canada we've had a good response and we've handled this well. And what I hope comes out of this is the recognition that public health, not only is it important, but we need to figure out a way to make the system more integrated, more uniform, and where we all share the same data and have a consistent message, because that's going to really play a big role going forward in the future. Now, Canada, unfortunately, we have this tendency to compare ourselves a lot to the United States when it's anything anything with healthcare, right? So people will say, yeah, you know, our response wasn't great, but at least we're not the States, eh? And it's true, the United States has probably had one of the worst responses, if not the worst response to COVID in the entire world. But I think that, quite frankly, particularly to the students who are interested in public health, I think you should aspire to more than just saying, yeah, we're better than the States. I think that we need to start comparing ourselves to countries that have been really, really successful at this COVID response, because those countries all tend to have integrated health systems, and they include public health as part of their integrated health system so that they can share data right from primary care providers easily. And there's a small example I'll get to in a second with that. I also want to caution the students that are on this call who are looking forward to being involved in public health and driving it forward, and good for you for doing that. Be aware of something that I call the money trap. And this is something that happens in Canada because Canada, healthcare is political in Canada. This is an article from April 16th, 2019, where the Conservative government of Doug Ford had proposed cutting spending to public health by $200 million. And that's the headline. The headline wasn't reducing the number of public health units from 35 to 10. It was, we're going to cut $200 million. And when you take a very simple look at the optics, the optics, if you just take a top level soundbite kind of view, is government's cutting public health in the middle of a pandemic, right? And I can just guarantee that in the next election, the Liberals and the New Democrats, when they run against the Conservatives, they're going to bring this up. You can guarantee that they'll say, well, the Conservatives wanted to cut $200 million from public health. We're going to restore that. Look where that brought us, right? Because that's a nice soundbite. It sounds good on TV. It doesn't talk about all the problems that public health had before all of this, but it sure does sound good. And there's the but. Because people on this call are interested in public health. And I'm going to ask you to actually go a step further and don't just listen to the sound bites, because that's just not enough. And because just restoring that $200 million in funding and putting public health back to the way it was, as we've seen, isn't actually good enough. We need to improve the system and make it better. Here's a great article from October 7, 2019. And it talks about the eHealth Ontario scandal, where $1 billion was actually wasted on electronic records. And I point this out because despite the fact, and this is true because I actually updated our EMRs at that time in something called an eHealth, e-prescribe project. And so I was well aware of what was going on with eHealth at the time. Despite spending $1 billion, we still don't have integrated electronic health records in this province, right? If I have a patient, they're on my EMR. If they go somewhere else to another doctor, I can't send that information electronically. We can't appropriately collect that data electronically. We can't analyze it in an aggregated, anonymized manner effectively to determine what trends are available. And as I mentioned, we have a whole bunch of public health departments that still use paper charts. So despite spending $1 billion, our system is in disarray and disjointed. And so spending money isn't the only solution. What's important is to actually have more of a vision for public health and focus on that. Because if you actually look back at the Conservative plan, for me, that plan was actually really good because it had fewer health units, which means I personally wouldn't be reporting to 2 different public health units. I'd only have 1. And there was actually a call in there to move to an integrated health electronic record system where all public health units were going to use the same software so they could share data in an anonymized aggregate manner. There was proposed for a clear line of communication where the public health units that were on the ground, the 10 regional ones, would report directly to the Ontario one so that the communication would be stronger and better. Now, full disclosure, my personal opinion, because I actually looked at that plan, would be they would never have saved $200 million. Like that wasn't going to happen. You might have saved 50 million in back-end costs because you'd have less administrative staff, you'd have less payroll department, you'd have less, with electronic software, you'd need less people. And my personal opinion, again, full disclosure, I think that 50 million should have been reinvested into frontline staff at the very least, because we've seen just how a small investment from public health makes a big, big return on an economic basis in the long term. But what it represented was, at least it was a vision for integrated, a flawed vision for integrating, but it was. And I encourage the students that are on this call, as they're thinking about public health, to look at that instead of looking at the actual amount of money that's being spent, and focus on this vision, because by the time that Maham and Jacqueline graduate from their degrees with honors and distinction, no doubt, the pandemic will be over. And we won't hopefully have to deal with COVID because we're getting vaccines this year. And by that time, we should no longer have a pandemic, God willing. But you know what we'll still have? We'll still have a country that hasn't banned trans fats, right? We'll still have a country where public health hasn't got a proper way to advocate for that. And that's just one of the issues. You've got all sorts of issues that public health should deal with. And you guys know this: youth substance abuse, opioid crisis, physical inactivity, health inequality, social determinant, like all this stuff is still going to be there after the pandemic. And if we want to address these issues proactively, and if you want to take the learnings of COVID-19, and if you want to get that early return on investment and really focus on that, we need public health to be stronger. We need the integration there. And we need clear, consistent communication. You can't have one public health department saying one thing and another not putting that in their messaging. We need clear, consistent messaging going forward in order to address that. So those are sort of my thoughts on it. There is the standards field where I do a little bit of self-promotion. Say, if you're really interested in my thoughts, you can follow me on Twitter at drmsgandhi.com. Or if you're looking for a good cure for insomnia, you can subscribe to my blog. It's justanoldcountry.com and get notified whenever I write something of note. And with that, I'm going to turn it back to Maham and Jacqueline. I'm not sure which one of you is going to take the questions, and I'm happy to answer questions. I think I've left some time for that.
Much for that incredible presentation, Dr. Gandhi. We've already had a number of questions, so I'm just going to jump into them. But if any of the attendees do have any more questions, feel free to write them in the Q&A as we go through. So the first question we have is, as public health professionals, we know that fragmentation and working in silos within the public health system is ineffective for many reasons. With this, how do you think we can work towards integration and a common and consistent voice for public health across not only provinces, but the nation at large?
Yeah, so the very first step, certainly in Ontario, and it's something I tried to promote when I was president, but the very first step has to be every public health unit has to have the same electronic records keeping software. And I don't care which one it is. I honestly don't, because as I mentioned earlier, I'm not a public health specialist, right? So I don't know all the data that you're looking for, but you have to have the same software so that at least you can communicate with each other. So at least you can collect the data in the same way. So if you're collecting data about how many heart attacks you've got the same standards, because believe it or not, there can be different standards of how you collect this information, so that everyone's on the same consistent playing field, and so that you can at least talk to each other. And you know, true story, for example, one of the things public health is trying to do, and before the pandemic, which I think was a good thing, is they wanted to get an idea of how many people are vaccinated, how many children are vaccinated, right? So they came up with this system called Panorama, which is where physicians like myself, when we vaccinate someone in our offices, we were supposed to input that data into Panorama. There were some problems because the previous health minister said, oh, just send a paper copy of the immunization. We're like, no, it should be electronic. And so there's some problems there. And that's fine, and I think that's a good idea. But now, of course, we're into COVID vaccine territory, right? So we're trying to track everyone who's getting vaccinated. Are we using Panorama? No. Government has developed another system called COVAX, right? So all the COVID vaccines are being tracked on a separate system than all the usual vaccines for things like tetanus and polio and stuff, which is, I mean, it's kind of ludicrous. Like, why should I, as a physician, have to look at two different systems? So get the same software is the short answer.
Yeah, definitely. Our next question is asking, so as health is a shared responsibility between the federal, provincial, and territorial governments, including the management of public health, do you think that this has also watered our response to COVID-19 due to this fragmentation and lack of communication among these players?
Yeah, unfortunately, it has. And I'm not saying that health shouldn't be a shared responsibility. It quite clearly needs to be, the way the Canada is set up, with especially with the Canada Health Act, right? Because the federal government does contribute a fair bit to healthcare, but you gotta put in a structure that works for everyone instead of the current structure. And prior to COVID-19, there was no talking about how to run that properly. So hopefully we can take the learnings of what was unfortunately a very poor response to COVID and use that to advocate for a unified structure.
We have a question about sort of the misinformation during the pandemic among the general population. So the question is, how do we balance messaging, relaying a sense of urgency about COVID-19, balancing that without creating a sense of panic within the general population?
Yeah, so that's a tough question, and I wish I had the exact answer for that. I do know that when you look at countries that were able to convey a sense of urgency, everyone was on the same page, right? And so it may be a situation where we have to take and Eileen de Villa, I think, has done a great job in Toronto, for example, but it might be a situation where we say, you know what, Toronto Public Health, London Public Health, North Simcoe, don't talk about COVID. Let the messaging just come from a central office, because at least if there's consistent messaging, then the public, when they're looking at misinformation, they look at things where, this health unit said this and this health unit said that, and they use that they use that as a way of saying, oh, they don't know what they're talking about, and it really hurts trying to convey that sense of panic.
So our next question says, you mentioned things like integrating systems where we all share the same data and have a consistent message, similar to other countries that you mentioned that have been successful with this pandemic. According to this person's understanding, many rural areas in Canada lack the technological infrastructure, and they're asking, how can we work to integrate care if these issues still exist, and what are the first steps that we can take to achieve this in a rural setting?
Yeah, and so certainly, rural Ontario has suffered from having slower internet speeds, because internet speeds are becoming very, very important for healthcare. I will say, having said that, I will say that when I did my tour of the province as the OMA president, I did go to a whole bunch of rural areas, and things are actually, they're not as fast as the big cities, for sure. But they, for what we need for transmitting data, for integrating some of the stuff that we do, I think is actually already there right now. Because the amount of data, we're not talking about sending video files and stuff like that. We're talking about sending Excel spreadsheets and that sort of thing. So I think that technology actually is there right now, so long as everyone uses the same software.
So this person is asking, now that we are sort of calling for a greater communication and integrated system, what has been the biggest roadblock in making this a reality and actually implementing a unified health communication system in Canada?
Yeah, so that's where I had that comment in my slide about the bureaucracy, right? It is, the healthcare bureaucracy in Canada is enormous and very, very resistant to change. And in fact, it was again, I don't want to sound like I'm political here, because I'm trying to be as nonpartisan as possible. But it actually was only 2 years ago with the current government where the number of VPs was reduced from, I think, 21 to 13, right? Because I had 21 VPs in the Ministry of Health, and they all had their little sort of fiefdoms. And whenever you wanted to change something, get everyone to agree, the bureaucracy really kind of got into the way. And so we have to figure out a way to have a vision first. You need to have that vision, and then you have to communicate that vision and say, and you need leaders who will say, you know what, this is the vision that we want to take forward, and this is the vision for how we want public health to be and how the system should be integrated. And that's tough. Those type of leaders are few and far between.
Yeah, kind of similar. I know in one of my public health courses, they really emphasize, like you were saying, vision, except they were talking about it in a sort of NGO sort of like separate organization sense of like they're emphasizing in order to have sort of proper management and proper implementation, you have to solidify that vision, and that vision needs to be consistent with everyone that's part of the team in order to move forward. And our next question says, how do you anticipate the COVID vaccine rollout will go given the lack of integration between all of the public health units?
Yeah, so there, the good news with the vaccine rollout is because so many people, there has been a real effort on a provincial level to make sure that all the vaccines that we get are used up. And so the good news is that we're actually a little bit ahead of where I thought we'd be a couple of months ago. I didn't think we'd get nursing homes and frontline healthcare providers treated until sort of mid-February to early March. Actually, that's what we anticipated at the OMA. And so the fact that we're getting nursing home residents treated now is great. Actually, we're a couple months ahead of schedule. I don't believe it's a concern in terms of rollout, simply because we have 10,000 family practices in the province of Ontario. And I know from when we do flu shot clinics, I know that we can do 100 patients a week, right? And so that's 1 million doses a week. I know that can be done. I know it's easy to do. The problem is the supply. And I don't have a good line of sight on why the supply chain slowed down for us. I don't know what the agreement was that the Canadian government had with Pfizer and why all of a sudden our shipment is going to be delayed, which was reported, I think, yesterday or today.
So we've seen a number, I would say, of healthcare innovations or policies that have been fast-tracked during COVID. And so, and potentially things like telehealth that have really increased during the pandemic. So just from your perspective, are there any innovations that have come out of COVID that you would like to see stay after it's over?
Yeah, certainly I would say the virtual care, as you described, is probably the biggest change that people have made to their practices. And I certainly would like to see virtual care continue in some form. I want to make sure that virtual care is tied into your own physician or your own nurse practitioner, or whoever your primary healthcare provider is. That's very, very important, because I do think that there's the potential for harm in overdoing it with virtual care when you're not meeting someone who you have an existing physician-patient relationship with. So if you look at organizations like Kaiser Permanente in the States is one that's quite famous for their virtual work, and they provide a very high level quality of healthcare. 40% of their visits are virtual, right? Whether it's electronic email, whether it's video visits, whether it's phone call. So those, I'd like to see that fleshed out, and I'd like to see that continue, but done in a way that ensures that it's really your physician who does that care.
So our next question is asking, do you think that the government's handling the pandemic well, or do you think they're playing too much with politics?
Yeah, so great question. I think, if I look at the provincial government, there's a few things. I think I'd say, I'd give them a B. just because I think I would never want to be in their situation. I would never want to be making those kind of decisions. I think they've done some things right with trying to promote the social distancing, and I think their advertising is great. I think certainly, opening up, giving hospitals more funding, which has happened, to open up the alternative health beds in Collingwood. We've got an alternate health facility opened up just as a direct result of their funding. So that kind of stuff has been okay. I think we're perhaps a little late to some of the lockdown recommendations. I think delaying some of that wasn't very good. Federally, I'd have to say not as good, maybe a C. And that's primarily because I really don't understand this deal that they have with the vaccine companies, with the drug companies. We keep hearing about the fact that they were providing 11 doses per resident of Canada, or that's how much they bought, but that's fine, but it doesn't really do us any good if they don't show up. And if we get all these production delays, that doesn't do us any good. And I'm mindful of the fact that Theresa Tam, I believe it was early March, said that, you got to get off cruise ships and we've got to start closing the borders. And the Canadian government waited. I'm not sure why they waited, but they waited for a few days. And you don't do that when you're Health Canada, the leading health doctor in the country says you got to close the borders. You don't wait, you do it right away. So those two things I'd say the federal government fell down on.
Thank you. So this is the last question that we have. It's an interesting one. So this person has said that Germany observed greater quality patient care and integration between providers in regards to patients with chronic conditions such as COPD and diabetes when using a bundled payment structure. So do you think that the healthcare system in Canada could have greater integration if there was an implementation of a bundled payment system, which they've said has been successful in increasing integration in Germany?
Yeah, so there's if you look at bundle payment structures, I actually had to look at that because Ontario is experimenting with something similar. It's not quite the same, but that Ontario Health Team model that's being proposed is similar to that. Germany, again, one electronic medical record system, data is completely interchangeable. Patients have access to their own files and their own test reports. Those kind of things provide the support to have an integrated healthcare system, and they provide the support for the bundled payment system to work. And certainly when I looked at it, when I was president, there were three things that were really important to make bundled care work. One was strong physician leadership, and the second was to have good governance, and the third, and was thought to be most important, was to have the IT nuts and bolts in place, right? So you could track a patient, because right now, if someone goes into the hospital, they get admitted, the hospital uses one piece of software, they get discharged, the family physicians use a different piece of software, can't communicate back and forth, can't track the patient, can't say, okay, yeah, we've actually reduced the number of admissions easily with that. So yeah, Germany did have some benefit, but don't forget the underpinning of the software that was so important to make that work.
Great, thank you so much. Those are all the questions that we have currently, but thank you for your presentation and the incredible insights that you were able to offer. And we have recorded this presentation. It will be available on our website. And if you do have questions for Dr. Gandhi or would like to connect with him, like he said, his Twitter and blog is up, and we encourage you to give him a follow. So thank you so much again, Dr. Gandhi, for your time.
Thank you very much. Always a pleasure.